Okay, we're going to get started in this last session of the day. I'm glad those of you who've decided to stay to the very end. So we're going to do this is on audiologic outcomes, and everyone will be introducing themselves.
Good morning, I'm Nicole Rea. I'm a clinical audiologist at University Hospital in Newark, New Jersey, which is the main teaching hospital for Rutgers, New Jersey Medical School. And I'm going to be talking about insufficient cochlear implant magnet retention. These are our disclosures and our team. I want to just take a minute to acknowledge our team, because every single person whose name is on this list has either had a patient who's had magnet retention difficulty or has had to listen to an audiologist complain about it. And it's because it causes poor sound quality, and that can range in severity for our patients. So when we first started this project, we did a quick lit review and found that Posner published a study back in 2010 that was a case series of 11 patients who had magnet retention difficulty, and 10 of those 11 were obese. What is important to talk about for these patients is that that was when all the magnets were axial, and so we started to wonder, are we having more of a problem now with MRI-compatible magnets? More recently, Atkins Group published that 24% of patients with off-ear processors were having a retention difficulty, and that 90% of patients who had a skin flap measuring more than 10 millimeters were going to have a retention-related event. And so really our objective was to find, is a high BMI associated with magnet retention difficulty, or RMD? We wanted to see if there's any other factors that could contribute as well, and to see, were we really seeing worse retention with MRI-compatible magnets? So the CDC looks at BMI, and there's a range that bases off of the age of 20. And so we did a systematic review of adults 20 plus from 2018 to 2023. These surgeries were conducted by 2 otologists, and they were programmed by 6 different audiologists. And we counted individual ears as individual data points. So we had 192 ears total with an average age of 55 years. Our average BMI was 28.5, which is in the overweight category. And most notably, over 75% of our patients had a BMI that was overweight, so greater than 24.9. We stratified our processor type by the type that was selected by the patient and the audiologist at the evaluation. And so that comprised of 115 patients who selected just on-ear systems, 14 that selected just off-ear, and 63 patients that selected a dual system. So in all, 27 patients had MRD, and we found that there was a significant rate increase in MRD based off of age, younger ages being more likely to have a problem with retention, as well as higher BMI and race. We did not see an association for sex at birth. We're very happy to report in that our cohort, we did not see a difference between manufacturers, so that's great to hear that everybody has the same problem as everyone else. But when we looked at each company individually in their latest 2 generation of magnets, we do have some differences. So we have a small population of advanced bionics patients during this time period. We only started to work with them in 2018, and they released their 3D implant shortly after. So we just don't have a very large N, but we did want to still discuss them because one patient did have a issue that required a surgical revision. When we looked at our Cochlear 500 series and 600 series implants for our cohort, we are seeing a significant increase in magnet retention difficulties. We assume this is because we lost the 6 magnet. And for our Med-El patients, we know that Med-El has had an MRI-compatible implant for over a decade. So when we group their Synchrony implant and their Synchrony 2, and compare that to the Synchrony 2 S-Vector, we are not seeing a difference in magnet retention. For all companies, we do see an increase in magnet retention difficulties that's significant. Specifically for our dual processor population, of those 18 patients, 16 of them couldn't use either processor initially. And we hypothesized that the reason the dual processor number is so high is because our audiologist had a suspicion that retention could be a problem, and so steered the patient towards a dual system. We are seeing an increase in BMIs as a relation to magnet strength, but it's not significant across all manufacturers. But we will note that with our 600 series implants, we are using significantly more 4 and 5 magnets than we were previously. Okay. So our interventions, our most common intervention at activation after we've determined that there's no swelling is to really try to help the patient separate their hair, move any braids or any other reason why they may be getting poor retention, and then having a really frank conversation with the patient to ask if it's okay if we cut their hair. A lot of our patients are very proud of their hair and it's part of their identity, so it's not something that we want to do if we don't have to, but we know how to do this now, where we can just shave a small portion for the headpiece or the coil. We also had to use compression or retention headbands at activation for these patients. 5 patients, one of them was bilateral, had to have their activation aborted, which is devastating to have to say, we have this technology, now you can't use it today. One patient used a manufacturer-supplied investigational magnet and headpiece that was not at activation. He had to come back. It did not work, and ultimately that had we revised to thin his flap. Overall, 16 off-ear processors had to be exchanged, which I don't need to tell any of the audiologists in this room how much time that wastes. And 2 patients, for a total of 3 ears, underwent revision surgery to thin the flap after everything else failed. They were both successful. We had no complications. However, it did delay their activation by around 3 months. Long-term, all of our patients with on-ear processors that could only use an on-ear processor and who had MRD are using the strongest commercially available magnet. And 8 patients, and these are adult patients, continue to keep their head shaved under the magnet and are using a retention device or a headband. So we're finding in our cohort of patients, younger age and BMI were both separately associated with higher levels of MRD, but BMI could not accurately predict appropriate magnet strength. We found that race was a significant factor associated with MRD. 22% of this cohort of patients were Black, but 48% of our patients who had magnet retention difficulties were Black. We are seeing, again, in our cohort alone, that the 600 series had a significantly higher proportion of retention difficulties as compared to the 500 series, and that in general for cochlear and med-el, higher magnet strength is associated with higher BMI. So overall, we need stronger magnets, but when we're trying to investigate for stronger magnets, it is critical that we need increased racial diversity in our study populations. We would also like to see some uniformity in magnet selection. I would love for software interoperatively to be able to advise the audiologist and the surgeon if the flap is too thick and to consider thinning it then. We are currently noting BMI at the time of implant evaluation and discussing the possibilities of magnet retention issues. It's not something that we're comfortable with. I think, unfortunately, we're getting a little bit more comfortable with it, but we just don't have enough training to know about healthy weight. We are encouraging our surgeons to measure the skin flap at the time of surgery, and from what I've been told, since I'm not a surgeon, they do have to do that before they inject lidocaine. We have invested in a surgical-grade electric razor with disposable blades to teach patients really how short the hair needs to be. We're discussing establishing relationships with nutritionists and referring to our bariatric team. But really, we would encourage all of you to create a retention protocol that meets your center's needs. Thank you.
All right. Good afternoon. My name is Greta, or Margaret is my real name, and today we'll be talking about speech recognition outcomes of a clinical trial investigating expanded indications for cochlear implantation. Is this not the clicker? All right. So this is our wonderful team at UNC that I'd like to take a second to thank, as all of our work isn't possible without a collaborative team. And here are our disclosures. All right, so all the data that we'll be talking about today is coming from a multi-center clinical trial that was conducted across 5 sites and sponsored by Med-El Corporation to investigate an expanded indication for cochlear implantation. So at the time that the trial was started, device labeling included individuals with bilateral severe to profound sensorineural hearing loss who had limited benefit with appropriately fit hearing aids. And as many people have discussed at this conference and in other places, research has shown individuals receiving a CI outside of this strict candidacy criteria have benefited on measures of speech recognition, localization, and quality of life. The primary aim of this clinical trial was to expand FDA-approved labeling for Med-El cochlear implants to include adults who have moderate to profound sensorineural hearing loss and obtain limited benefit from appropriately fit hearing aids. So the methods of this study: the inclusion criteria were adult CI candidates who were 18 years of age and older, and they are fluent in English. The degree of hearing loss for both ears was a low-frequency PTA, including 250, 500, and 1,000 hertz of 40 dBHL or greater, and high-frequency thresholds 3,000 to 8,000 hertz of 65 dBHL or greater. For the ear to be implanted, the aided word score on a CNC word list was 10 to 60%, and the aided word score on the contralateral ear was less than 70%, again with a CNC word list. The participants in the sample were 44 subjects, 19 of which were female. They were recipients of a Synchrony Flex 28 or Flex Soft electrode array, and their age at surgery ranged from 23 to 91 years. The intervals that we'll talk about today is their baseline testing and the 6-month follow-up interval. They completed speech recognition testing with the implant ear alone, both including CNC words and quiet, AZ vowel sentences and noise. So this was with the hearing aid best fit at the preoperative interval and the cochlear implant at the 6-month interval. All speech recognition testing was presented at 60 dB SPL with the participant seated 1 meter from the speaker and the contralateral ear masked and plugged as needed. They also completed subjective questionnaires, including the Abbreviated Profile of Hearing Aid Benefit, or the AFAB, and the Speech Spatials and Quality of Hearing Scale, or the SSQ. So on to our results. So our first measure was the CNC word task with the cochlear implant alone. So on the y-axis, we have % correct with a higher score, meaning better results. And on the x-axis, we have we have interval. And in the light blue, we have the baseline, and the 6-month we have in the darker blue. So what we're showing is the average performance on CNC words prior to surgery was 26.5%, and by the 6-month interval, the average was 52%, showing a significant improvement on the CNC word task and quiet. They also completed AZ vowel sentences and 10 dB SNR with the cochlear implant alone. Again, % correct is on the y-axis, with better score being higher on the graph, and our interval is on the x-axis. So the average performance at the baseline visit was 23.5%, and at the 6-month was 47%, again showing significant improvement with the cochlear implant alone, and that contralateral ear masked or plugged as necessary. They also completed subjective questionnaires. So here is the AFAB. On the y-axis, we have perceived difficulty. So a lower score is considered better, as in they're perceiving less difficulty in these areas and on the questions being asked in the questionnaire. On the ease of communication, background noise, reverberation, and subscale, and then the global score, they had a decrease in perceived difficulty with the cochlear implant on at 6 months compared to their preoperative abilities, which is great, showing that with the implant, they're having less difficulties in these different areas in their everyday life. There was not a difference in the aversiveness subscale, though what aversiveness is measuring, we would not expect there to be a significant decrease in this area. They also completed the SSQ. So on this task, it's perceived ability, so a higher score is considered better. It's on a 0 to 10 Likert scale, and it assesses the speech, spatials, and quality for subscales, and then a total score, asking them questions in each of these areas and them to rate their ability to their performance on them. So again, we saw a significant improvement in their perceived abilities in these areas as well, which is great. So our conclusion, we saw significant improvement in speech recognition, both in C&C words and quiet and AZ-BOW sentences and noise, completed at a 10 dB SNR. We saw an improvement in perceived hearing abilities with the cochlear implant use at 6 months out, a decrease in perceived hearing difficulties with CI use. So overall, individuals with moderate to profound sensorineural hearing loss and an aided word recognition score of 10 to 60% experienced improved outcomes with the cochlear implant compared to their preoperative abilities with an appropriately fit hearing aid. So this shows that may be a viable treatment option going forward. All right, thank you for your time.
Hello, I am Kate Johnson. I am an audiologist at the University of Utah Hospital, and I'm going to be presenting some of our preliminary data on audiologic outcomes of cochlear implantation in the early post-activation period. I would like to acknowledge our primary investigator, Dr. Neil Patel, as well as all of the co-authors on this presentation. These are our disclosures. So the objective of our study was to address a gap in our knowledge by evaluating the rate of cochlear implant audiometric performance change during the initial post-activation period. As we all know, cochlear implants can greatly improve sound detection and speech understanding, and a lot of the previous research estimates that the plateau in performance can be anywhere from 3 to 12 months post-activation. Having accurate estimates is going to be vital for counseling, realistic expectations. We all know that as audiologists, one of the most common questions we get asked is how long is it going to be before I reach that optimum performance, as well as helping with the clinic efficiency. So knowing that we are trying to reduce the number of times that we have to see those patients, and having this information can help with that. So we did aided testing at 1 week, 1 month, 6 weeks, 2 months, 3 months, and 6 months post-activation. We were looking at thresholds, CNCs, and AZ-BIO. AZ-BIO in quiet was done for everyone. Noise testing was completed if patients reached a 75% correct threshold. We captured data logging at all of our intervals except for 6 weeks. We did some quality of life measures pre-op and 3 months post-op, and oral rehabilitation was highly encouraged and resources were provided to patients, but it was all done independently. Our inclusion criteria were patients that were above 18 years of age, either unilateral or bilateral cochlear implantation. We left our inclusion criteria rather broad. The only exclusion criteria was lack of the ability to have adequate follow-up, prelingually deafened adults, and anyone that had greater than 20 years of unaided hearing loss in the ear that was implanted. So as of the time of our data analysis for this presentation, we had 46 patients with a median age of 70.5 years, about half female, half male. 14 of our patients were SSD or asymmetric hearing loss, and 8 of them were sequential or a second hearing loss, or a second cochlear implant. And you can see here the different etiologies as well as our manufacturers. So looking at our results, I wanted to share first just our median data logging, just to show that data logging was pretty good for all of our patients, looking at that median of about 12 to 13 hours a day, with the range only going down to a little bit below 9 hours, which is pretty decent for an adult population. The first area that we'll talk about that we're all pretty aware of is that our pure tone average does improve significantly rather quickly. So at that 1 week, we see that significant decrease in PTA, and we see that stabilize starting at 1 week. Potentially, if we looked at this, I would assume that activation would show a very similar reduction in PTA. Looking at our CNC phoneme score, you can see the trend of increasing from preoperative to 1 week, 4 weeks, and 6 weeks, showing a significant change. I will mention that some of our data, or some of our participants were missing data points, and so this is a paired t-test that could be a little bit off just based on the fact that some of those pairs were not accurate. But you can see this increase happening in the early 1, 4, and 6 week period. CNC words, a similar trend happening with increases that were significant at 1 and 4 weeks, and things stabilizing after that 6 week mark. We see, again, a similar trend for our AZ Bio in quiet, seeing that stabilization happen after that 6 week mark as well. The big thing that we wanted to look at with this was actually the rate of change. So I have on this screen this graph that you saw previously for CNC words, and then underneath the percentage per week of change for each of these, or the median rate of change per week for our participants. And this is important to look at because we know that a patient that goes from 0% to 40% is going to be probably pretty happy with that score, but a patient that goes from pre-op 40% to 50%, while the numbers don't sound that different, the perception of change is going to be rather different. So you can see here that from 1 to 4 weeks, we have about a 4% change per week. From 4 to 6 weeks, about a 3%. From 6 to 2, 6 weeks to 2 months, we have about a 2%, and then things really start to fall off pretty drastically, going below 1% for the median change per week. So the conclusions we can draw from this is that plateaus can be achieved as early as 1 month, and on average hitting about 6 weeks to we can start to be able to tell patients that, and tell CI recipients that they can expect really fast rates of change for their first 2 months, and potentially even consider using rate of change as an outcome measure in addition to speech scores, so that patients, again, in those categories of going from 0% pre-op to whatever score they end up with versus starting at 60% pre-op, those are going to be very different, or very similar numbers that could mean very different things. In the future, we would like to look at the relationship between the rate of change and its correlation with quality of life measures. Do people have better quality of life outcomes if the rate of change is faster, slower, etc.? The rate of change for speech and noise, as well as the impact of oral rehab on the rate of change. We will also be looking at quality of life measurement plateaus and seeing when those happen as well. This is, as I mentioned, interim data, so we will have more forthcoming in the future. Thank you.
For a whole different universe now. Hello, everyone. My name is Louise. I'm a speech pathologist and a researcher in Quebec City, and I will be your very last presenter, so thank you for being here. We have nothing to disclose. We undertook this study because there is a need for a better understanding of the longer-term functional outcomes in adults. It is important to improve the quality of professional support for these users and to improve their social participation and quality of life. We know that quality of life is a multidimensional concept that includes physical and psychological aspects as well as social participation. But what is social participation? It refers to a person's involvement in activities that provide interaction with others in society. And why qualitative research? Because it provides insights into the patient's experiences and it can uncover issues that researchers may not have previously identified. These are our first 15 participants. We have interviewed more since then. There were 12 women and 3 men between the ages of 21 and 84. They participated in interviews with Zoom. They had 1 implant at the time of the interview and were French speakers, as myself. They represented a variety of profiles in terms of onset of deafness, age at implantation, and life situation. All interviews were transcribed. A thematic analysis was performed and allowed us to identify 4 main themes. Today, I will focus on the first 3 themes. Okay, now the results. Theme 1 regards participation restrictions despite overall life improvement. It means that all participants told us that their CI improved or changed their lives. However, nearly all of them also reported participation restrictions. In other words, occasions when they neither could do the same things nor enjoy certain activities as much as any other person. I coined a phrase to capture this. It changed my life, but. Many participants feel somewhat limited in their choice of social or leisure activities. Movies and restaurants are especially avoided, but social life has improved. And who is better qualified than the participants themselves to tell us what their experience is like? In the first extract, this woman said, "I don't really go to restaurants. Movies, it's so-so. Live theater, it's too echoey. But to be honest, it just made my life better." In the second extract, this woman does not participate in her usual activities as fully as she expected, but her social life has improved. "I've returned to 75% of my activities," she said. And the relationships of this young man also improved. He said, "It hasn't changed my life, but it has simplified it a lot." Theme 2 regards the role of educators played by our participants. I've generated the phrase, "we educate people." It means that a majority of participants expressed feeling responsible to make their communication partners aware of their situation during social interactions. This phenomenon seems to be quite common in most of their social interactions. In the following extracts, participants talk about the general public's lack of awareness of CI, and sometimes, as told by the woman in the first extract, even in the healthcare system. Someone said to her, "I've never seen anything like it." It was someone at the clinic. I think we have a tendency, since we've had our implant, to educate people. This other woman refers to the discomfort that she often faces and the need to explain her situation to communication partners. For more than half of our participants, it's a burden to explain and to educate. The first 2 extracts express this. This woman says, "I don't feel like explaining. I don't feel like it." Next, this man said, "It's also been a job to make the people I work with understand, to make them understand that it's not a bionic ear." But for others, it just can be fun to educate people and to raise awareness. This young woman, implanted as a child, says it's not bothering her at all and that she likes to educate people. Theme 3 is, in my view, the most interesting theme, and I would say the most surprising one. When we asked people to tell us which word they usually use to describe themselves, we discovered that many felt uncomfortable to use either deaf with a small d or hard of hearing. The phrase I chose to illustrate this is, I can hear, but. These two extracts show that both the word deaf, small d, and hard of hearing might not be exactly accurate. The first woman said, I've come to realize that when you use the word deaf, automatically there is this uncomfortableness. So I'm going to use hard of hearing, but I don't like that term because I don't think it's precise enough to describe what we are. And this other one balances between the two words. She says she's deaf, but she can hear with the implant. And then she finally says, I know I'm not hard of hearing for real. In the first extract here, this young woman implanted as a child says, she's going through an identity crisis. It's like I'm between two worlds. I'm not hearing enough for hearing people, but I'm not deaf enough for deaf people either. The second extract also expressed a somewhat blurry identity. She finally says, I embrace the fact that I'm a deaf person who hears with a cochlear implant. I think the present results first speak to the importance of expectations and counseling in CI recipients. Prediction of outcomes based on speech perception scores might be fine, but we need to translate the prediction of outcomes into everyday situations because that is what people experience. During interviews, no one talked about their open set sentence recognition score. Instead, they discussed their daily lives, the activities they engage in, and the people they interact with. I think the results also speak to the inescapability to take a role of an educator. Research shows that the general lack of knowledge about deafness often results in individuals with hearing loss taking on the role of educator, especially at work. People who disclose their hearing loss in the workplace see it as an opportunity to educate and raise awareness. It's the same thing for people with implants. In the present study, not everyone viewed this role positively. Finally, I think the results speak to the importance of taking identity issues seriously because people need help to cope with these issues as they are related to quality of life and well-being. A majority of our participants expressed some discomfort regarding the use of the word deaf, with a small d again, but some were also uncomfortable with the term hard of hearing. There's this really nice article by Blackley and collaborators that suggests that identity is a central aspect of living with hearing loss and with CIs. To conclude, although the results cannot be generalized to the entire population, this study highlights important elements related to quality of life and social participation. And in research, we're at the stage where the relationship between cochlear implantation, identity, and social participation need to be further explored. Thank you. Thanks to the participants, and I especially wish to thank Laurie Duquet, an SLP student who contributed to data analysis. Thank you.
Thank you to all of our presenters. There are mics on either side of the room, so if you have a question for our presenters, please come up to the mic. All right, as we wait, I have a question related to looking at the perception and feelings of the group of adults and their age range from 21 to 84. Do you have a sense of the differences that may exist in that younger cohort versus the older cohort? Did you look at that of trends that might exist since 21-year-olds' expectations of social engagement is potentially different than an 84-year-old's potential of perspective of social engagement?
Of course, this is a small study with a few participants, but maybe there are differences between those who were implanted as children versus those who were implanted as adults. I don't think it's an age factor. In my view, it's related to age at implantation or the timing of implantation.
Thank you.
I have a question for Dr. Johnson about, I know in my practice, I find that, I know you noticed that the oldest person in your study was 77, is that correct? Mm-hmm. And I'm noticing a real big difference in my 80-plus-year-olds, that they're not making that kind of same trajectory, they're taking longer. And of course, I think that makes sense. It's not like it's a surprise, but how are you kind of dealing with that, or what have you seen either anecdotally, or are you going to look at that? Because that would be interesting to me to see, because they're, I think, a slightly different population.
Yeah. I think that anecdotally, I agree with that statement that people in that older population of 80 plus are going to maybe have that slower rate of change. That's not something that we specifically are looking at in our current study. That doesn't mean we're not going to expand into that. But I think that in order to do that, it would involve, because age doesn't necessarily predict explicitly cognitive function. And so I think adding some sort of cognitive measure to this, and that relationship between cognitive function and the rate of change, I assume there would be a relationship there, and definitely something of interest, and could potentially help with that counseling as well. Again, anecdotally, we already kind of counsel that way, of patients that have already been diagnosed with dementia or cognitive decline of any sort. That is a discussion that is involved in our counseling during the evaluation period.
I have one other question related to body mass index and retention. It's going to become very obvious that I am not an adult audiologist as I asked the two questions that I wanted to ask. But do you have any sense of, if we think about weight and BMI, and your younger participants had greater retention issues than your older ones, do you have a sense of how that might translate to teenagers or older children related to their weight and body mass index?
So I'm a pediatric audiologist also, which is probably why this project was so important to me, because in the few adult patients I do see, it's very frustrating. And it's the opposite problem that we have with small children. We are going to look at it. We have the data, we just haven't run the statistics yet on the younger groups, because they have to be subdivided based off of age. You can't just clump the 9-month-olds in with the 12-year-olds.
Yeah, I would definitely think that there's going to be a younger children versus older children and teens as you're looking at weight changes and body mass index. So.
Yeah. I will say, just anecdotally, we definitely see magnet retention issues with teenagers, especially teenage girls, and it just adds one more layer to how do we get this to stay on? How do I get you to wear it? But how do I not make you lose your identity with your hair?
Okay, do we have any questions from the audience? Jolie, do you have any more questions? Okay, well, thank you all for joining us for this very last session of the day. Thank you again to our presenters, and I hope you all had a wonderful conference, and we'll look forward to seeing you in Boston.